Hello and welcome to the infectious disease rotation at Mercy Fitz Hospital. I'm Dr. Stephen Katz, and alongside Dr. Angela Lawton and Dr. Gold Madison, we will be teaching you infectious disease during the weekdays. I will cover most Mondays, Tuesdays, and Thursdays the first 3 weeks of the month, and Doctors Lawton and Madison will be handling the remaining weekdays. What I will do is around 7 a.m. send out a secure chat message to each resident or student on service with a one or two consultation assignment, which you will review and then present to me at around 11:10 a.m., usually on one pavilion or another designated specified spot. When reporting the consultation to me, there are several things that I need to know and that you need to tell me. Number one, and you can write these down, number one is the reason for the consultation. Number two, allergies, whether the patient has any particular medication allergies. Number three, if relevant, a pregnancy history. Number four, the medications that the patients are already on. Period. Sometimes I say period because I'm so used to dictating and using the word period at the end of each sentence, but I'll try to limit that as much as I possibly can. Then you would need to move on to an ID-focused history. Obviously, I need to know the symptoms. Have they ever happened before? If so, what was the diagnosis and how was it treated? I need to know if there were any particular exposures that are relevant to the case, such as injuries or insects or pet exposure or significant travel history, especially international travel. We do see a lot of patients that come from other countries, including Africa, the Middle East, Asia. So it's very helpful to know where they have been in recent history. Is the patient immunocompromised from a particular illness or from a particular medication is often very important as well. Does the patient have any prosthetics or a pacemaker? This is important to know because these devices can get infected and also are at risk of getting infected if there is bacteremia or any other sort of infection. So it's important to know if there are any prosthetics or pacemakers and so forth. Does the patient have any other chronic illnesses that could produce non-infectious fever, such as DVT, such as malignancy, such as any sort of collagen vascular disease? So that's pretty much the ID-focused history. In terms of the physical exam, I'd like you to start with what's called the Tmax at 24 hours. That's telling me what the highest temperature has been over the past 24 hours. And this is because temperatures will fluctuate normally throughout the day, so you really can't get an idea of whether or not somebody has fever that is still operating unless you've looked over the past 24 hours. So that's very important. Heart, lungs, abdomen exam, you'll get better with them as you do them over and over and over again. They're to be expected. I expect that you do at least those examinations. If the patient has any upper respiratory or oral, nasal, ear complaints, I'll expect an oral cavity exam, a throat exam, nasal septum exam, as well as an ear exam, including visualization of the external canal and the tympanic membrane. You should get proficient at that. If the patient has any sort of headache or mental status change or is otherwise unresponsive, you need to check and make sure they don't have meningismus. You cannot miss a diagnosis of meningitis. Oftentimes in the elderly or the middle-aged, the neck is somewhat stiff from guarding or arthritis, but if you can find any kind of small degree, 5-degree segment of supple neck and mobility, that pretty much rules out meningismus. So you don't need to show that the entire range of neck flexion is supple. If you have any questions with that, just ask me. Wound examinations are kind of the bane of infectious diseases because they're time-consuming and difficult, but must be done in order to make a diagnosis of wound infection. Is there purulence? Is there erythema? Does the wound probe down to bone? All these things need to be known or need to be discovered. And if a patient is obtunded or intubated, somehow you've got to know if they have any wounds on their backs or their heels. This can be done by looking at pictures in the chart. They would be under the media section of chart review, or talking to the nurse or wound care and finding out what the wounds may look like. In addition, if a patient is obtunded, they're not going to tell you that they have a back wound or they have a perirectal abscess or any sort of rash back there. So in those patients, you simply need to get some help and try to turn the patient and see what's going on that other half of the body that you would may not want to examine, but which needs to be done to be complete. So that's pretty much on the physical examination. I also want you to report relevant laboratory work. The most important labs are the CBC and the diff. As you already know, white counts are important in infectious disease. If they're elevated, that's often due to bacterial infection. Not always. You can have stress reactions or steroid-induced leukocytosis. If they're low, that can be viral. If they're normal, that can be non-infectious fever or even viral or even bacterial. Sometimes bacterial infections will cause normal white counts or even low white counts, but those typically are associated with high bands in the differential, which I'm going to talk about next. So in addition to knowing the white blood cell count and any other abnormalities in the blood count, such as the platelet count, because if the platelets are low, you certainly don't want to give an antibiotic that could further decrease them. So any kind of significant abnormality, you probably ought to tell me as well. But the differential is supremely important and should be done at least once in a patient that has a suspected infection. Bacterial infections will produce a large degree of bandemia, typically, not always, but typically. Viral infections will produce a more mononuclear or lymphocytic predominance. A stress reaction or leukemoid reaction, typically from steroids, will produce a high number of PMNs, but not bands. So in patients with high white counts, 17, 18, 19,000 from steroid administration, if they have a lot of bands in their differential, you need to think that more than steroids, something more than steroids could be contributing to the white count, such as a bacterial infection. The reason why steroids and stress reactions do not produce bandemia is because what they do produce is demargination of mature PMNs from the endothelium, resulting in a mature PMN predominant leukocytosis. The other thing that can produce some degree of leukocytosis is hemoconcentration. So be aware that dehydration can contribute to an otherwise falsely elevated leukocytosis. Cultures are important. Blood cultures I need to know the results of, sputum cultures, urine cultures. And I also need, and this is very important, to know whether the cultures were done before or after antibiotics were administered, especially the negative cultures, since most antibiotics will be negated by positive cultures will be negated by prior antibiotic administration. That is in the blood and the urine. I can't tell you how many times in a patient with clear-cut urosepsis, we can't figure out why the urine culture is negative. Oh, by the way, they received a couple doses of cefepime before the urine was collected, and this can be found out from looking at the time notations in the chart. So cultures are important. Imaging, relevant imaging, chest x-rays, CAT scans, ultrasounds, MRIs, if relevant, need to be noted during your presentation. So after you've amassed all this information, what I would like you to do is put the relevant data into an AI-generated app, such as Open Evidence. And I want you to come up with some sort of reasonable differential diagnosis given the data that you have collected in the chart and on examination, and then come up with some kind of impression and present this to me. Then, before the presentation, however, I want you to also come up with a treatment plan, and which would involve you at least choosing an antibiotic that you think might be appropriate. And if the antibiotic is chosen, I want you to then go to Up to Date and read the monograph section on that particular antibiotic that you have chosen. So any antibiotic that you are recommending that could be used, I want you to know about, and I expect you to know if there are any relevant drug-drug interactions involved, or if there's any other important relevant information in regards to what you learned from reading the monograph. What I did pass on in looking at the laboratory, I want to kind of jump back to the laboratory section that I talked about, is the creatinine. I failed to mention that, but I need to know that as well as the WBC and DIF. And that's because most of the antibiotics that we use are excreted through the kidney, and dosage reductions are then necessary in patients with renal insufficiency. Otherwise, toxic levels of the antibiotic will build up, and the patient will then be subject to any kind of dose-related toxicity, such as CNS toxicity, seizures, cytopenias, renal failure, ototoxicity from not dosing correctly because the creatinine is elevated. But getting back to the impression, I've already told you, I want you to come up with a diagnosis and then an antibiotic, which I want you to read about before presenting. And then I will have already seen the patient and formulated a diagnosis and a plan myself, and can adjust it depending on any other new information or insight that you folks have provided. And that's about it for the introductory talk, and I will see you on the floors.